Welcome. Today, we're tackling something you are going to see all the time, a high calcium level on a lab report. We're going to build a super clear step-by-step game plan to take you from that initial ping to a solid diagnosis and a plan you can feel good about. Okay, let's dive right in. We'll kick things off with the two key hormones running the show. Then we'll walk through the workup you absolutely have to know, zero in on the main culprit, primary hyperparathyroidism, and figure out who actually needs surgery. We'll also cover a major mimic you can't afford to miss, and then we'll wrap it all up with a handy little pocket card summary. So picture this. You're in clinic and a lab result pops into your inbox for a 68-year-old patient. Bam! High calcium, just found incidentally. Your mind starts racing, right? What's the differential? What's the very first thing you do? That exact scenario, that's our starting line. To even begin to answer that, we've got to go back to some basic physiology. How the body handles calcium in the first place. Trust me, once you nail this down, figuring out what's gone wrong becomes so much easier. And really, there are just two main players you need to keep in your head. Okay, so think of them like this. Vitamin D, that's your absorber. Its whole job is basically to pull calcium in from your gut, from the food you eat. Simple. Then you've got parathyroid hormone, or PTH. That's the regulator. It's more of a real-time, minute-to-minute manager. It's telling the kidneys, hey, hang on to that calcium, and if things get low, it'll even pull calcium out of the body's biggest bank account, your bones. They work in this constant dance to keep your calcium levels in a super tight range. So, with that physiology fresh in our minds, let's get back to our patient. The workup for this isn't about just, clicking a bunch of boxes and ordering a huge panel of tests. No way. It's about asking a series of really smart questions, starting with the single most important one. First things first. Is this for real, or is it just some lab error? Your very first step, always, is to repeat the test. Make sure this is a persistent finding. Okay, once you've confirmed it, we get to the absolute fork in the road. This is the big one. You have to measure the serum calcium and the parathyroid hormone level at the exact same time. Seriously, the relationship between these two numbers, it's everything. All right, so this table right here, this is the great divide. Just look at the patterns. In a normal situation, calcium is normal, PTH is normal. Makes sense. But look at primary hyperparathyroidism. Calcium is high, and PTH is also high. That tells you the parathyroid glands themselves are the problem. That's what we call PTH-mediated hypercalcemia. Now, flip that. What if calcium is high, but the PTH is low or even undetectable? Well, that means the glands are working properly. They're trying to shut down. The problem is coming from somewhere else. Think malignancy, something pumping out a PTH-like protein. And this brings us to an absolutely critical clinical pearl. You have to burn this into your brain. If your blood calcium is high, your parathyroid glands should shut down. Period. PTH production should be suppressed way down low. So, if you get a lab back that shows high calcium, but the PTH level is technically in the normal range, don't let that fool you. That is not normal. It's what we call inappropriately normal, and it's a huge red flag for a PTH-mediated problem. So let's circle back to our patient. Their lab showed a confirmed high calcium and a PTH that was, you guessed it, inappropriately normal, right there in the upper end of the range. So that puts them squarely in that PTH-mediated category. And now we can really zero in on the most common cause by a long shot. So what in the world is primary hyperparathyroidism? Well, in the vast majority of cases, we're talking over 80%, it's just a single benign tumor called an adenoma on one of the 4 tiny parathyroid glands. This little adenoma has basically gone rogue. It's just churning out PTH 24/7, completely ignoring all the body's normal feedback signals to stop. And if you look at the classic patient profile, it fits our patient to a T. It's way more common in women, and it usually pops up right around this age. The hypercalcemia is often pretty mild, nothing too dramatic. And here's another great clue to look for. Because PTH tells the kidneys to get rid of phosphate, you'll often see a low, or at least low normal, phosphorus level on the labs. Okay, great. You've connected the dots. You've made the diagnosis of primary hyperparathyroidism. So, now what? And this is a huge point. The next step is not automatic. It's a real decision point, and it requires some careful thought. This really is the central question, isn't it? We know that surgery to take out that rogue adenoma is the cure, but not everyone is actually a candidate. A lot of patients with really mild, asymptomatic disease can actually just be observed safely for years. So who gets the green light for surgery? Well, the guidelines give us a really clear checklist. Surgery is the way to go for anyone whose calcium is pretty high, more than 1 milligram per deciliter above the normal limit. It's also indicated if we're seeing signs of end organ damage. We're talking about things like kidney function starting to decline, or osteoporosis, a T-score of -2.5 or worse, or the presence of a vertebral fracture. Let's really zoom in on that last point for a second. Take a look at this spine x-ray. See those arrows? They're pointing to vertebral compression fractures. That's what years of high PTH does. It leaches calcium right out of the bones, making them brittle. If you find a fracture like this, even if it was just an incidental finding and the patient has zero back pain, that is an absolute indication for surgery. At that point, the disease is definitely not asymptomatic anymore. But wait a minute. Before you pick up the phone to call the surgeon, there is one critical mimic you absolutely, positively have to rule out. Because if you miss this, you could send a patient for an unnecessary and totally ineffective operation. We have to be sure we're not dealing with an imposter. So on one side, you have our main diagnosis, primary hyperparathyroidism, which often causes a lot of calcium to spill into the urine. But on the other side, you have its doppelganger, familial hypocalcuric hypercalcemia, or FHH. It's this benign genetic condition where the body's calcium sensor is just built wrong. And the key difference, just like the name says, is in the urine. These patients actually hang on to calcium like crazy, so their urine calcium is surprisingly low. So, how on earth do you tell them apart? Well, thankfully, it comes down to one simple test that directly measures what the kidneys are doing with calcium. You order a 24-hour urine collection and you calculate something called the calcium to creatinine clearance ratio. If that ratio comes back less than 0.01, that's it. You've got your answer. It's FHH. And this is a total game changer because for these folks, surgery is not the answer. It won't fix a thing. All right, we have covered a ton of ground here. We've gone all the way from a single lab value to a definitive management plan. So let's boil all this down into a super high-yield summary. Think of it as your clinical pocket card for hypercalcemia. Okay, here's the algorithm. You see an incidental high calcium? Step 1, confirm it. Next, check PTH and calcium together at the same time. High calcium plus a high or inappropriately normal PTH, you're almost certainly looking at primary hyperparathyroidism. Then, run through your surgery checklist. Is the calcium really high, or are there signs of kidney or bone damage? But before you call surgery, always rule out FHH with that urine ratio. And one last little pearl for you. Don't forget to check and fix your patient's vitamin D level before any intervention. It'll help prevent some nasty post-op hypocalcemia. And there you have it, a really structured, logical approach to a super common clinical problem. But the real takeaway here goes way beyond just calcium. This whole pattern of thinking, of checking a hormone level and looking at it in the context of its stimulus, that's the heart and soul of endocrinology. So the real question to chew on is this: how can you take this same logical framework and apply it to the next endocrine puzzle that lands on your plate?